So thank you, Dr. Chandrakant, and thanks organizer for giving me this opportunity. And thanks to all. So I am presenting the Nivo versus Gemcis in advanced urothelial cancer. It was a late-breaking abstract in the last ESMO, and it is a positive trial. So this is Nivo plus. We all of us know that Gemcitabine-Cisplatin is the standard of care in first-line platinum eligible patient with advanced metastatic urothelial cancer and bladder cancer. Now the CheckMate is 901 clinical trial that addition of Nivolumab in these settings in the first line, there is a significant benefit in terms of overall survival and progression-free survival. So the background is Gemcis is all of us know that first line standard, and with a response rate of around 40% with a median OS of 15 months in the reported study. Still now there is no novel agent that improved the overall survival when added concurrently to the platinum-based chemotherapy in first-line settings in the unresectable cohort. There is unmet need remains in the first-line settings for treating this patient. So we report this final Gemcis chemotherapy plus chemotherapy in this CheckMate study. So the inclusion criteria was in previously untreated unresectable urothelial cancers on renal, pelvis, bladder, ureter, urethra, cisplatin eligible patient with a good performance status. Nivolumab 360 mg day 1 plus Gemcis is the standard dose versus placebo control arm, and followed by Nivolumab monotherapy with a maintenance till unacceptable toxicity or progressions up to 24 months, that is 2 years. So primary endpoint of the study was OS, PFS as per the BICR, and the key secondary endpoint is PFS by the subgroup by the PDL1 expression and the overall response rate. So the median follow-up of the study was 33 months. If we look at the baseline characteristics, most of the baseline characteristics were similarly matched in both of these, like performance status, tumor type, PDL1 expressions, and the ethnicity and the gender also. So the liver metastasis is also included in this study. So completed 6 cycles of the chemotherapy as per the protocol was near around 74%, and the discontinuation rate is quite low in both Gemcis versus Nivo plus Gemcis arm. So the overall survival, the primary endpoint at the 2 years is at 46%, and the 12 months it is around 70%, with a median OS of 21.7 months with a hazard ratio of 0.78 in the Nivo plus Gemcis as compared to the Gemcitabine-Cisplatin. And the overall survival in the forest plot, which will look the subgroup, almost all of the subgroup, irrespective of the PDL1 expression, previous systemic therapy, and liver metastasis, the hazard ratio is more favored for the Gemcis rather than the Nivo plus Gemcis rather than the Gemcis. Only the US population subgroup cohort, they are not benefited with the addition of Nivolumab. The cause remains not known to all of us. So the PFS as per the Nivo plus Gemcis, median PFS is 7.9 months versus 7.6 months, and the 24 months PFS rate is around 23.5% with addition of Nivolumab and Gemcitabine-Cisplatin. Again, the PFS in the subgroup, all the subgroup in irrespective of the age, ethnicity, and the regional status, PDL1 expression, liver mets, previous systemic therapy, PFS is more better in the addition of Nivo plus Gemcis. Only if we closely look, those who are active liver metastasis and those US populations are basically the hazard ratio is not so important and lucrative in the Nivolumab arm. So the BICR sensitivity analysis, the hazard ratio of 0.74 in terms of PFS in the Nivo plus Gemcis. Again, the objective response rate was the key secondary endpoints. The 57% were the overall objective response rate in the Nivolumab plus Gemcis group, and was comparison to 43% in the only chemo arm. Again, the median duration of response is quite lucrative, 9.5 months in Nivolumab plus Gemcitabine. And the complete response rate and duration of response is also high in the Nivolumab plus Gemcis group. So duration of response in the 9.5 months, the median overall objective response rate that was maintained in the Nivolumab plus Gemcitabine as compared to the Gemcis. So the subsequent line of therapy, any immune checkpoint inhibitor, the PDL1 expression, those who are progressed on the Gemcis, They received pembrolizumab, avelumab, atezolizumab as per the guideline, as per the standard of care. These cohort are also doing better in this population, likely maybe due to carry forward effect on the first line immune checkpoint inhibitors. Again, we look at the adverse effect, the quite manageable, and the classic adverse effect of all immune checkpoint inhibitor that was reported in this study in terms of anemia, neutropenia, fatigue, decreased appetite, vomiting, asthenia, thrombocytopenia, like this. So summary, nivolumab plus gemcitabine-cisplatin demonstrates statistically significant and clinically meaningful improvement in the overall survival and PFS versus gemcis alone in the first-line unresectable cohort. Overall response rate and clinical rates are notably higher with gemcis and the concurrent immune checkpoint inhibitor plus chemotherapy in combination with the deep and durable responses. The CR rates is nearly double, and the median duration of response is also very high with a maximum 2 years of nivo treatment. The combination of these nivo plus gemcis resulted in no new safety signals till now, and the safety profiles was consistent and established safety with these agents in the prior immunotherapy trials. So health-related quality of life is also maintained, and the nivo plus gemcis is the frontline current standard of care, and combination, and it improves overall survival in these settings with the result support nivo plus gemcitabine-cisplatin based chemotherapy as a new standard of care in the patient with unresectable metastatic urothelial cancer. Thank you.